everyone, and welcome to another Heart for PCOS interview. Today, we have an incredible guest speaker joining us for Heart for PCOS. Dr. Jeelani is a double board-certified reproductive endocrinologist and infertility specialist, a graduate of Ross University School of Medicine. During her medical training, Dr. Jeelani received numerous awards in the areas of fetal medicine and reproductive medicine. In addition, she has authored a variety of publications and book chapters in well-known journals highlighting cutting-edge REI advancement, and has presented at national and international conferences and symposiums focused on advancements in women's health. Welcome, Dr. Jeelani. Thank you for joining us today.
Thank you for having me. I'm very excited to be here, and it's a topic very near and dear to me, so thank you.
You're more than welcome. So let's start from the beginning. When a patient comes to see you and suspects they may have PCOS, how do you make a diagnosis?
I start off by saying that the most common time we find out that we have PCOS or maybe suffering from it is when you're actually trying to get pregnant. So it comes as almost a shock that now I'm finding this out, because by the time you're trying to get pregnant, you're in your mid to late 20s, early 30s. And I start off by also saying that it's a diagnosis of exclusion. What that means is it's really, really vague, and it presents very differently in everybody. And I think as somebody who has PCOS, I really struggled to find a doctor to teach me that. I was really like, oh, well, you don't look like a PCOS patient. You don't look like this. And I got pigeonholed into something else. So I start off by saying it's very different. Everyone can have it and present very differently. And what we want to do is we want to rule out everything that mimics PCOS. And once we rule that out, we rule in PCOS. I start off by explaining the types of testing we would do and when we do it. And it's not like high blood pressure where you say you need 2 separate readings of this and then you diagnose it. It's you need 2 out of the 3 criteria. We use a criteria called the Rotterdam criteria to diagnose PCOS. And we walk through what that means and what that testing would look like.
That's wonderful. And thank you for clearing up that PCOS looks different on different people, because I think there is a lot of dismissiveness when you don't fit into a particular box. So it's important for people to know it doesn't matter your age, your color, your size. It can affect anyone. So I wanted to clear something up from the very beginning. A lot of times when patients go to see a provider that may not know very much about PCOS and PCOS treatments, they are told automatically that they are going to have problems with infertility and conceiving. Can PCOS patients get pregnant naturally?
Of course, yes. Like everyone with PCOS presents differently. And like I said, some people have the metabolic component, meaning they have the different effects of PCOS. Some have infertility and some have neither, and they just get diagnosed incidentally. So it truly varies by person to person.
So after a diagnosis, what are the first steps you take with a PCOS patient when they're having issues with infertility to address infertility?
Yeah, so I usually, because that's all I do, that's my bread and butter. Most of my PCOS patients do come here because they're having trouble conceiving. We start off by talking about a full assessment, right? Because you don't want to make any assumptions, and you can have couple things at once that's causing your infertility, not just your PCOS. So we start off with our testing. We talk about egg count and quality. We talk about making sure our tubes are nice and open. We talk about making sure the landing page of the embryo, which is our uterus, is nice and healthy, and there's nothing that's going to interfere with implantation. And of course, you can't forget the third component, which is a sperm, which is a really important component. So we start off by addressing all of that testing and what that would look like.
That's great. So women who undergo treatments for PCOS but are still unable to conceive naturally are, supposing, good candidates for assisted reproductive technologies, including IUI and IVF and other experience high pregnancy success rates. Can you please break down this process and how it may differ for PCOS patients, if it does differ for PCOS patients?
Yeah. So there's a couple of things that do differ, but most of it is very similar. So if, say, we do all our testing and the sperm looks good, the tubes look good, the eggs are there, and the only problem is with PCOS, the most common problem is that we don't ovulate. So we get very irregular cycles, and it becomes very hard to time a pregnancy. So what we do is we start with something simple called ovulation induction. So we say, okay, well, the eggs are there, the brain is there. They're just not talking to each other. I always say they're angry at each other. So let's reinstate the love. And we give a fertility pill called letrozole, Femara, or Clomid. Those are all sisters. You take a pill for 5 days. We watch the egg grow. And what that pill does is it hides the ovary. Just imagine if I hid your partner. You may go on full panic mode. Like I'd start calling my husband, like, where are you? That's exactly what the brain does. So it makes more food, gives the ovary some more attention, and you react by making an egg. You make an egg, we track it, and we give you one shot to release the egg. It's called a trigger shot. So now we know and confirm that you've ovulated. You can either do timed intercourse at home that day, or we could do what's called an IUI, meaning intrauterine insemination. That's where we take the sperm, we wash it, clean it, fortify it, and put it right up top at the uterus. They still have to swim through the tubes, get to the egg, fertilize, and come down to implant. So it's important to know, because I didn't know this. As a patient, I always said, okay, well, I'm going to do ovulation induction for 6 months, and then I'm going to do IUI for another 6 months. And I always tell my patients, would I have changed it now? Hindsight's always 2020, but going into it, I wish somebody would have said, in the setting of normal sperm parameters, and when your only problem is PCOS, and that was back then I thought that was our only problem, that adding in an IUI adds in 1 to 2% more success. It doesn't really significantly change the outcome, but here I thought, like, oh my God, I'm going to do this IUI and it's going to work, because that was the missing thing. So it's important to know what all of these interventions add to your success as well.
So how does IUI differ from like IVF? Is there a difference?
Yes, a really big difference. So with an IUI, we give you an oral medication, sometimes injectables, likely not in a PCOS patient, to super ovulate. And then we put the sperm top, but a lot of the job of the egg and sperm meeting, fusing together, becoming an embryo, coming down to implant, is left up to nature. When we do IVF, we give you injection medications, which mimic your own hormones, that FSH we just spoke about, food. So these are synthetic food for your ovaries to grow. So you grow with PCOS. The downside is that we're going to touch on. What's different is that we have a lot of eggs. So we're going to respond, and everyone's going to say, oh, we're PCOS, I hyperstimmed, but it's not necessarily a hyperstim. You're going to have a lot of eggs because that's what your antral follicle count is. It's a high antral follicle count, which is one of the diagnostic criteria of PCOS. So they all kind of tie in together. So you take this injection medications for 10 to 12 days. Then we do an egg retrieval. That's when you go to sleep with IV sedation. We do an ultrasound. At the tip of our ultrasound is a little needle, which enters the follicles or the eggs and aspirates or sucks the egg out. That day, your partner gives us the sperm. We wash it, clean it, and fuse them together. That's IVF, in vitro fertilization. Then they grow in the lab for 7 days. And it's important to remember, not all of your eggs will become babies, because with PCOS, not all of our eggs are good. So our attrition, meaning the number dwindles down throughout these 7 days, as our eggs are converting to embryos.
Wow, it sounds like a big process, but I'm so glad that you explained it, because it made it a lot easier to understand what happens. Because I dealt with infertility, but I only got as far as doing injectables. I never went through the process of the IUI and the IVF, and I always wondered what the differences were. So thank you for clearing that up. So when a patient is going through first finding out that they're having trouble getting pregnant, and they go through this for a while, at what point should a patient with PCOS consider IVF?
It depends. It's multifactorial. So I use age as a number one predictor of your outcomes, right? That dictates everything, independent of your egg count, whether it's high or low. Your age dictates our outcome. So if the guidelines say if you're under 35, 1 year of unprotected intercourse, you want to intervene through a fertility doctor. If you're 35 and over, 6 months of unprotected intercourse, you want to intervene with a fertility doctor. Now, the type of modality, whether it's timed intercourse versus IUI versus IVF, truly depend on your age, your numbers. And I like to add in long-term and short-term goals, because one of the things I wish I would have done sooner is say, okay, well, I'm 32 or early 30s when we're having number one, and what that looks like. When am I going to have two? When am I going to have three? And, gosh, now I'm 40 and having three. So it just, hindsight truly is 2020, but that's something I learned from my own journey.
So we're talking about the process, but what about preparing for this process? Why is it so important that we practice self-care with PCOS, and when we begin infertility treatments that we want to optimize our health?
Yeah. So one of the things that comes with PCOS is you have a metabolic component to it, which is not really spoken about, right? Um, and it's surprising because as a doctor and seeing other doctors, I always get this look of, oh, you have high cholesterol. Gosh, you're so thin. Oh, you have high blood sugar. Why? What do you eat? But it's just innate. It's in my genetics. I don't know what came first, chicken or the egg, whether I had PCOS first and I had this metabolic syndrome, or is my metabolic syndrome the root cause of my PCOS? But what that translates to is that you're a higher risk of gestational diabetes, you're a higher risk of heart disease, you're a higher risk of elevated blood pressure and pregnancy complications. So it's really important that you address your overall health, not just for that time being, but longevity. Like, you want to be around for your kids. And how does this kind of transpire to your future?
And I'm so glad that you're bringing this up, because that is why we are here. We are here for Heart Month, and we have to talk about some of these risk factors. So we know patients with PCOS after they conceive are at higher risk for pregnancy loss and pregnancy complications, some of which you mentioned: miscarriage, gestational diabetes, and preeclampsia. So how do you counsel patients to reduce these risks?
So I always talk about, and I always do a fasting panel. I always look at their cholesterol, their lipid panels, or same vice versa. Their lifestyle is really important. And I tell them that because as soon as you touch on lifestyle, and I did this too, you start feeling guilty, right? And then automatically it's human nature to get very defensive and say, well, I eat really healthy. So I want to make sure that patients understand it's not what you're doing. It's a lot of it's just our genes or genetics. So while the person next to me who may not have this can eat a lot worse than me but have a better metabolic profile than me, it's nothing that you do. But now, knowing and educating ourselves about our body, we're going to use this as a tool to amplify and improve our outcomes. So Mediterranean diet, foods lower on the glycemic index, less processed food, more fruits, more vegetables, more fishes, supplements. I like supplements. I know a lot of doctors kind of are not, they don't want to make a bold statement, but I took myo-inositol or inositol preconception, postconception, during my pregnancy. It's an insulin sensitizer. So without necessarily being on metformin, although I was on that too, I feel like anything I could do to control it, I wanted to, right? So you can't take medications for your cholesterol, but if you improve, do 2 to 3 times a week, moderate exercise as well with a healthy diet, you can really improve your outcomes.
Let me ask you another question. If when we're talking about lifestyle, because with PCOS, we're predisposed to higher stress levels. And when you're going through IVF and IUI, you're also more predisposed to higher stress levels. So are there ways that we can reduce that stress, or strategies that that you can give people to help kind of alleviate some of this?
Yeah, I think educate, right? Because once you go in, once you educate yourself and are well informed, it's you can alleviate a lot of that stress, because I think stress builds up when you don't know what you're walking into. I did this. Everyone was like, "Oh, you're PCOS. You're going to take a pill and you're going to get pregnant." And when it didn't happen, I was dumbfounded. Then I started looking at what I was doing, and then I would go on this like highs and lows. So I would do this crazy keto, cut out all my carbs because I'm PCOS. It didn't work, and then I would go back on this like binge of, well, it's not working. Let me do the exact opposite, and all of that causes one, physical stress, because imagine all that inflammatory response my body's going through, but then actual mental stress because I'm blaming myself for things that are really out of my control. So really understanding, what does your body need, what is it going through, educate yourself, and set proper expectations.
I love that because you kind of hit the nail on the head that with this condition, whether you're trying to get pregnant or not, there's so much guilt that comes with it. And we're probably harder on ourselves than other people are on us. And I think it's just mostly because we want success in our health and in pregnancy. So it's really vital that people can connect with a provider who understands that. So I love the message that you're bringing with that. So again, we're here for Heart Month. So I want to talk about a topic that may not be comfortable for a lot of patients to talk about, but since it is Heart Month and we are here talking about it, I wanted to discuss some cardiovascular risk factors that can occur with pregnancy in PCOS patients. So women with PCOS have higher risk for preeclampsia, eclampsia, peripartum cardiomyopathy, and heart failure during delivery. While these can all be very scary prospects, we know that 80% of cardiovascular disease is preventable, and it starts with education. So when would you consider a patient to be at high risk for cardiovascular issues during pregnancy with PCOS?
So I always do a baseline panel. And if you have higher cholesterol, higher hemoglobin A1C, higher fasting blood sugars, you're automatically at higher risk because it's telling me you fall in that metabolic component of metabolic syndrome, independent of your weight and your height, right? Because typically we think, okay, obesity linked to PCOS, linked to heart disease. That's not true. You can be, and I have aunts who are very thin with PCOS who have the same premature heart disease and follow that same trend as PCOS patients do. So getting baseline parameters, and if those parameters are abnormal, you're at higher risk of those pregnancy-related and post-pregnancy complications.
So when someone is going through IVF and ultimately for those who conceive, how important is it to keep health checks and have your hearts monitored throughout pregnancy and treatments?
So the biggest predictor, the most acute predictor is your blood pressure. So you want to follow the recommendations. There's no intervention just yet, or there's no predictive test that says if you test here, you're going to have preeclampsia. If you test here, you're going to have heart disease, because there's no direct relationship. It's best to understand that, gosh, I am at higher risk. How am I going to prevent it? There's that preventative baby aspirin now. There's no study, which I just had a study idea. Maybe we should do it, right? PCOS, independent of age on a baby aspirin, does it improve pregnancy outcomes? Because they did it for older women and it did show it lowered the risk of preeclampsia on baby aspirin. So stuff like that, you make sure you're starting off healthy and continuing that throughout your pregnancy.
So what are some of the preventative measures we can take to ensure our health and the health of our pregnancy?
Yeah, this one's a little hard to do, but everything starts with your diet. If you can adjust and be stricter with your diet, then it's a trickle down effect, right? So start with your diet, then incorporate that mild to moderate exercise 2 to 3 times a week for 30 minutes. And then throughout your pregnancy, make sure we're at higher risk of gestational diabetes. So talk to your doctor and say, hey, I have PCOS. Do I need an early glucose tolerance test? Because although as much as we are OB-GYNs and fertility doctors, a lot of this is not connected. So make sure you're your own advocate and kind of ask about stuff like that.
That is so important that we advocate. And on that note, how important is it for patients and providers to actually communicate and sit down and talk through all of this? Because I think that's where a lot of us miss key information or key care, because I know sometimes I'm not always comfortable going into a doctor and talking about my symptoms. So how can we improve that?
Yeah, I think I'm biased. I think social media is really breaking down barriers that, stuff like this, Heart for PCOS, educational content, it's empowering our patient, right? Like 10 years ago when I first started, nothing like this existed. So I was a fertility doctor in training, but an OB graduated in OB-GYN, and I didn't know a lot of this because I didn't know what questions to ask. How should I start? Should I be ashamed that I don't know this? Or should I say, gosh, teach me about my body? But really just knowing that Your doctor does want to teach you. Well, I want to teach you, and that's why I'm on social media, and that's why stuff like this exists, because I want to empower you to ask the right questions, because although it may not apply to everyone, there are some that do apply to you.
Absolutely. Because if social media didn't exist, I wouldn't exist and I wouldn't be able to advocate and empower. So really important key point there. So I want to leave with like kind of a good message on this. So at the end of the day, we want people to be vigilant with PCOS, but with proper care from a provider like yourself, we can have good outcomes and healthy pregnancies. So let's talk about success rates for pregnancy and live birth with PCOS.
Yeah. So you said a point earlier, and I don't think a lot of people know this. And I still remember I did my own research and I took it to my fertility doctor and said, did you know the risk of miscarriage is slightly higher in a PCOS patient? And everyone looked at me saying, that's not true. It's age dependent. And I was like, no, I swear. Because I think they have this inflammatory process in their body and they just miscarry and their implantation's much lower, because that's what I struggle with. And I found very few, there's not a lot, but there's data on it. So I think understanding what your miscarriage rate is, understanding that it's not, one, not your fault, and two, these are normal embryos. So the pregnancy rate, and not everyone has it, once again, because remember, PCOS is really variable. The good thing is the prognosis for a PCOS patient is very good. You will eventually get babies and have 3 very beautiful babies. And if you're doing an IUI, it's very age dependent. It can range from 10 to 25 to 30%. IVF is anywhere from 50 to 70%, depending on whether you're doing genetic testing or not. And age is the number one predictor.
Yeah, that's so important that people understand and know that sometimes it may take a little bit longer in the journey, but there is hope, there is success, and same with me. I have 2 babies that aren't even babies anymore; they're big kids now. But it is absolutely possible. So, I would love to hear your final thoughts on why awareness is so important, why joining campaigns like Heart for PCOS are so important, not just for patients, but for providers and for researchers and everyone who supports us.
Yeah. One, for patients, it helps you get a lot of patient autonomy. 2, for providers, I don't think everyone has the same skill set. Like, had I not been a patient, I would have followed my textbook and said, no, that's not true. PCOS don't have a higher miscarriage rate. Truly found this out from researching. So I think there's so much to learn, and it's such a young field that we really can learn from each other. And I think from like primary care and from an endocrinologist perspective, PCOS, once again, is so variable and there's so many ways to treat it. And the most important thing is we want to increase your lifespan, and it starts from a young age. So from diagnoses, it's not take birth control, come to me when you want to get pregnant, because that's what I was told. But like, gosh, when I have a thick lining, what does that mean? What does cancer mean? Do I have cancer? Like, I'm just understanding what comes with it so you can take better care of yourself.
I am absolutely loving all of this information. You're incredible as an educator, as an advocate. So thank you for that. So how can patients connect with you on social media, your website, or if they want to come see you in practice?
Yeah. So I'm on social media, mostly on Instagram, but you can find me on all channels, including Twitter and LinkedIn. But it's Roohi Jeelani, MD. And if you want to see me, I'm a doctor at Kindbody here in Chicago. So you can go on our website and enroll, or you can message me and DM me, and I'm happy to connect and coordinate care.
I absolutely love it. I cannot thank you enough for taking the time to sit down with me today and clear up a lot of things about pregnancy and IUI and IVF and health and happiness for everyone. I hope you will continue to join me in the future for more interviews and education. And everyone, I want to thank you for tuning in to listen to our interview. And please follow Dr. Jeelani. I will make sure that all of her links are in the post along with the video. And be sure to check our schedule throughout the month of February. We have over 55 speakers, PCOS and cardiovascular experts who are here to help educate and empower. So thank you again, Dr. Jeelani. Everyone, thank you and have a nice day.